Good morning and welcome to these lessons of the Master in Child Neurology realized by Dr. Longo and I. My name is Guarnera and today we are going to talk about central nervous system vascular lesions. In particular, we are going to focus on neuroimaging findings. As we all know, stroke is a neurological deficit related to an area of hypoperfusion. Therefore, an area of hypoperfusion related to the certain cerebral artery, and therefore this is associated with a neuroradiological and clinical evidence of ischemic lesion. When we've got an acute stroke, there is the sudden onset of central nervous system injury. In particular, we can divide into ischemic disease and hemorrhagic disease. An ischemic disease is in relation to the interruption of blood supply related to a thrombus or an embolus, while an hemorrhagic stroke is often secondary to the rupture of a brain vessel. There is a great difference between adults and children because in adults 80% of strokes are ischemic and only nearly 20% are hemorrhagic, while in children 50% of strokes are ischemic and 50% are hemorrhagic. Therefore, there is no great difference between these two kinds. The incidence of stroke is also very different because in adults we have got 200 cases over 100,000 per year, while in children we have got nearly 15 cases over 100,000 per year. The mortality, the incidence of mortality is also very different because generally there's 1 to 3 children versus adult, and this is important. Not only because the mortality is low, but also because we're talking about long survival of these children. Therefore, the main point is not mortality, but the main point is the outcome: motor, language, behavior, epilepsy. Therefore, early diagnosis is crucial and tailored therapy is paramount in these children. Let's start with the pathophysiology of ischemic stroke. Ischemic stroke is related to the obstruction of a certain cerebral artery, and mainly due to two mechanisms: thrombosis and embolism. So we can say that thromboembolism is the main cause. Most of the ischemic stroke are related to the obstruction of the middle cerebral artery. We divide the middle cerebral artery into 4 main tracts, which are the tracts that are mostly involved in this pathology. We can say that the most important tract is M1, the first tract from the origin to the division of the middle cerebral artery. In particular, this tract M1 is split into 2 main parts: the proximal or medial, from which the lenticulostriate artery originates, and the distal part or lateral part. Why this division? Because the proximal section, the proximal segment of M1 tract is the origin of the lenticulostriate, and these small but extremely important arteries irrorate the deep nuclei, the deep gray nuclei. Therefore, an interest of these arteries is important for the outcome of these children. Another important segment is M2 tract. This tract is further divided into an anterior and posterior branch. Obviously, the more proximal, the worst. There are other tracts like M3 or M4, but these are mostly related to cortical infarct and are less frequent. Which neuroradiological investigation? It's good to start in a good way. Let's start with the CT. CT is often proposed in first aid, so the advantages is that it's very useful in critical patients that are admitted to the first aid, and assess the presence of bleeding. This is important because 50% of stroke are hemorrhagic stroke in children. But there are many disadvantages. At first, the use of radiation. As we know, in children there is a principle, a LARA, as low as reasonably achievable. We have to go with the less dose possible in order to have an answer to our question. And the important thing is that in the hyperacute phase, no ischemic lesions are clearly evident. And we have already said early diagnosis for an early therapy. This is the reason why MRI is paramount in these children in ischemic and hemorrhagic strokes. I propose this important protocol. One of the main sequences is the diffusion-weighted sequence. The diffusion is always accompanied by apparent diffusion coefficient map, the ADC, that is calculated by the scanner after the acquisition. And this is the most sensitive in the first hours for the identification of an ischemic stroke. This is a functional imaging, while the FLIR or T2 are morphological images. The FLIR consists in the fluid attenuation inversion recovery and is very similar to the T2, but the difference is that the fluid is attenuated, therefore is hypointense. And this is very important because strokes may be hyperintense. We also have the gradient echo or the susceptibility weighted images. These two sequences are very similar. Therefore, there are some scanners that perform gradient echo and other scanners that perform susceptibility weighted imaging. The susceptibility sequence is far better because it's more sensitive and gives a morphological appearance that is better than the gradient echo. We will see examples. The angio-TOF time of flight is an example of angio-MRI. The great point in this sequence is that we can see vessels, we can see obstruction or alteration, but without any contrast. And this is very important because contrast is a drug and because we're talking about children with a long life expectancy. There are other kind of perfusion that use contrast as a tracer, and perfusion as the ASL, the arterial spin labeling, that use the spin labeling as a tracer and no contrast. This is very important and we will analyze this sequence afterwards. These are some examples. Let's start with the first two images, as we see the diffusion-weighted imaging and the apparent diffusion coefficient. In this case, we can see that in the temporo-occipital territory, with extension to the optic radiation, we see a restriction of the diffusion that appears as an hyperintense signal on the diffusion itself and hypointense signal on the apparent diffusion coefficient map. This is the evidence of an acute ischemic stroke, and this sequence is extremely important. Here we can see the gradient echo and the susceptibility weighted image. These images are of the same patient at the same time, at the same level. Therefore, the great difference is that the susceptibility weighted image has a morphological plus compared to the gradient echo. Therefore, we can see that the contrast in the spatial resolution is definitely better. If possible, the susceptibility weighted image is better than the gradient. But as we said, there are scanners that allows only to perform gradient echo. Last but not last, these two important angio-MRI. At first, we can see a 3D reconstruction of a venous MRI, and the second, we can see the circle of Willis. Therefore, we're talking about an arterial evaluation of the circle of Willis and the main artery that depart from this circle. This is the protocol that is very useful for the diagnosis of stroke. This slide is extremely important not for helping the diagnosis itself, but for conveying the timing. Time is everything in life. Therefore, time is brain. We need to know when the ischemic or hemorrhagic stroke happened. Therefore, in the first line, we are going to analyze the diffusion-weighted image. In the last, the ADC, the apparent diffusion coefficient map. And in the middle, we are going to see the T2, that is similar to FLIR apart from the cerebrospinal fluid, and is important to give a morphological idea of a functional sequence like diffusion-weighted image. Within the first 4 hours, we can see that there is diffusion restriction, hyperintensity on DVI, and hypointensity on ADC. This is typical of an acute ischemic stroke. If we look at the T2 is not positive. Why? Because within the first 4 to 6 hours, the T2, the FLIR, the other sequence may be negative. Therefore, the diffusion may help us to diagnose an acute stroke and an acute stroke within 6 hours. So great possibility of therapy. In 5-7 days, we can see that there is hyperintense signal on DWI. On ADC, there is a difference because the signal is becoming higher. Because generally, after some days, there's the normalization of the ADC, while the hyperintensity on DWI lasts. And we can start having a look at this T2 with the hyperintensity on the left frontal region. This is definitely an ischemic stroke. After 10-14 days, there's something quite different. We can see that there's the persistence of hyperintensity on the WI. The ADC is quite normal, while on the T2, the signal is not so clear. Why? Because after 10-14 days, it is possible to have a fogging effect. The presence of macrophage in that area may alter the signal, especially on T2. But we know the history of the patient and we can understand that it is pretty normal. After 1 month, 2 months, 3 months, the lesion is chronic. Therefore, after some time, we will not have diffusion restriction on the WI anymore. The signal is very high on ADC, and after some time on T2, we will see porencephalic lesion. Therefore, the remnant of what the ischemic stroke has been. When we are talking about diffusion, what are we talking about? Diffusion is a parameter we use on resonance imaging and is based on the Brownian or microscopic movement of water molecules. Water molecules are generally very free to move around, and their movements are chaotic, absolutely. But if we're talking about an ischemic stroke or a stroke in general, we can see there's the lack of a blood supply in a determined region. Therefore, lack of blood supply means that we don't have glucose, we don't have ATP. Therefore, the sodium-potassium pumps over the membrane, over the surface of the cell stop, and therefore the water is allowed to enter, tend to an osmotic process. Therefore, there's a cytotoxic edema because it's very toxic toward the cells, and we have got, as we see, diffusion restriction. On the other hand, there's also vasogenic edema. Vasogenic edema is totally different. It's related to the lesion, to the barrier, and therefore there's not cytotoxic, there's no toxicity to the cell, and therefore this kind of edema, however present, doesn't cause a restriction to the diffusion. This is the main difference on radiological images. Another sequence that we were talking about is perfusion. Perfusion is an MRI sequence that analyzes the flow of blood into capillaries to a certain organ. And this sequence is based on signal changes induced by a tracer. The tracer may be a paramagnetic contrast, as in perfusion-weighted image itself, or may be something different. In arterial spin labeling or ASL, the tracer is not contrast. The tracer is spin labeling. Arterial spin labeling is, we can say, one of the most recent sequences, and is based to the evaluation of the blood flow without any contrast. The idea is that thanks to a coil at the level of the neck of our patient, we send a radiofrequency pulse. This radiofrequency pulse label or mark the spins of the arterial blood. The arterial blood flow towards the brain parenchyma. We have got the possibility to acquire at the level of the circular villus, brain parenchyma, wherever you prefer, and therefore we've got a marked image, an image of the brain with these marked protons. Afterwards, we acquire a control image. Control image is an image at the same level, but we do not mark the spins before. After the subtraction from the marked image and the control image, we have a perfusion map. A map based on the protons that were marked before. And this is an example. So, in the first line, we see 3 different images. The first is a top, I really can see the left middle cerebral artery. And this is possible because the second image is a diffusion weighted image in which I see a very extensive ischemic stroke affecting both the deep nuclei and the superficial tissue. Is very wide, is in the territory of the middle cerebral artery. Therefore, what I see in the angiograph is correct. What I can see in the last image, this an ASL, I can't really see a great perfusion of that area, but I can say a focal area of red color. This is called arterial transit artifact. This is an artifact related to the slow flow or related to a closed area of parenchyma suffering due to ischemia. The second line is related to the same patient after 16 weeks. The angiograph is quite normal, so there's a normalization, while on the T2 sequence, that is the second image at the bottom, we can see that there are porencephalic cavities, therefore the remnant of the ischemic suffering. And we see an hypoperfusion on the ISL at the last image in the same territory. So there is a match. Arterial spin labeling is a very well-known technique. There are various kinds of arterial spin labeling. This is a P-Castle, also called a pseudo-continuous arterial spin labeling, that is related to the way in which we give the pulse, in which we allow the marking of the spins. In neonate with acute stroke, it's very important because it provides clinicians with a fast and safe source of information. This is very important to have a safe and fast source of the information, and the presence of this early hyperintensity we can see in C may be a biomarker for neuronal hyperexcitability or cerebral reperfusion, and this is very important in order to plan a therapy for these neonates. We've spoken about sequences, we've spoken about incidents. Now let's go ahead. Let's see a little bit more about stroke. The important thing about stroke is there is a very kaleidoscopic entity, and is related both to age and the mechanism that is at the base of the parenchymal sufferance. I will split our group into two main subgroups, to have perinatal stroke and to have infant stroke. For both groups, we are going to speak about the ischemic and the hemorrhagic variants. Let's start with perinatal stroke, in particular with the ischemic perinatal stroke. In order to offer a proper diagnosis of a perinatal stroke, it's important to look at the symptoms, and in particular at the timing of symptoms which are related to the location of the obstruction. If the symptom presentation happens within 3 days, so between 1 and 3 days, generally the patient presents with seizures, and the lesion type is most prone to be an ischemic stroke. If the presentation is within the first few weeks, we have to think about a patient presenting with seizures, with encephalopathy, and therefore an hemorrhagic stroke. Sometimes the child arrives at 4-6 months with hemiplegia. This is a condition where we have to presume a previous ischemic stroke, the so-called presumed perinatal ischemic stroke. There are many risk factors, and the risk factors are related to the mother and to the obstetrician situation. The maternal factors may be infertility, primiparity, preeclampsia, infection, drugs, smoking, while obstetric factors may be prolonged rupture of membranes, chorioamnionitis, or placental strokes. Let's say that forceps and vacuum are less used nowadays. Therefore, we can say that there are many other factors at the base of this condition. Why is it important to know the risks? Because the goal is to prevent the risk. Some maternal risk may not be prevented, like preeclampsia or primiparity, but we can speak with the mother and avoid smoking or drug assumptions. These are the main characteristics of perinatal ischemic stroke. This was a child of 20 weeks of gestational age, and the perinatal age was 28 days. These lesions are unilateral, in this case the left hemisphere. Generally, in neonates, 60% of the cases, the middle cerebral artery segment that is mostly affected is M3, M4, in particular cortical branches, while middle cerebral arteries is affected in preterm. 40% of the cases lenticulostriate artery, departing from the proximal segment of M1. This is one of the cases I will present. This is a neonatal acute ischemic stroke. We are talking about the distal M1. Therefore, the lenticulostriate are totally free. We can see, let's start with these two last lines. This is diffusion, this is ADC. We can see that there's an area of diffusion restriction, is mostly parietal or frontoparietal. And we can see that this person had a perinatal suffering related to detachment of placenta. And this diffusion restriction relates to the hyperintensity here, over here on the T2. And this is a sign of suffering, a sign of ischemic stroke of a person of less than 30 days. On the other hand, we can have an ischemic suffering related to the proximal or medial tract of M1. Therefore, we can see here that the extension of the lesion is much more interesting. I'm going to start with the ADC, so the bottom line. Here we can say that there is an extensive ischemic stroke affecting the temporal lobe, the occipital lobe, the splenium of the corpus callosum, and also the frontoparietal lobes. On the ACC, the diffusion restriction is seen as hypointense, while on T2, these are different slices at different level of T2, we have seen the hyperintensity of the same region, indicating an extensive ischemic stroke of this child. This is a very rare case, and as you say, this is written raro because it's very rare, but pay attention. This is a case of an acute ischemic stroke affecting the left occipital lobe. In particular, this is an example of posterior cerebral artery ischemia. This diffusion restriction is related to a rare but important case in which the vertebral basal system may be affected. And this is another example. When we're talking about the vertebral basal system, we are talking about a system with all the vessels that are related to this system. In this case, we can see that there is diffusion restriction of the left cerebellar hemisphere, plus a little area of sufferance on the right cerebellar hemisphere, and a diffusion restriction also of the tonsils. In this case, we had an obstruction of the left posterior inferior cerebellar artery. And this girl presented with diplopia, torticollis, and ataxia. And these symptoms may explain what we saw on neurological images. Finally, we have arrived to the presumed perinatal ischemic stroke. That is a very interesting case. In particular, we talk about presumed because there are children, in this case a child, arriving with hemiparesis or hemiplegia. In this case, this is a child of 2 years old arriving with right hemiparesis. This porencephalic cavity causes an attraction on the ipsilateral ventricle, and there are also areas of suffering in the ipsilateral corona radiata and posterior link of internal capsule. Moreover, we can see here in the last image an atrophy of the left cerebral peduncle. This is related to a condition called the Wallerian degeneration, because after the sufferance, we got the neuronal and the axon degeneration of the tissue. How can we say that this condition is not acute, but is a presumed perinatal ischemic stroke, because when we look at the diffusion weighted image and the ADC map, we can see that there's no diffusion restriction. Therefore, this condition is not acute anymore, at least. We have analyzed the perinatal stroke, in particular the ischemic type of perinatal stroke. I would like to deepen our knowledge on the hemorrhagic stroke. When we speak about hemorrhagic stroke, we have to be sure that we are talking about a primitively hemorrhagic stroke, because sometimes ischemic stroke may undergo conversions to hemorrhagic stroke. So there's a bleeding at the level of an ischemic stroke. These are the main risk factors that can be maternal or neonatal. Maternal risk factors may be idiopathic autoimmune thrombocytopenia, therapy with aspirin, with anticoagulants or trauma. Neonatal factors may be vascular malformation, maybe lesion, vascular lesion as cavernomas, maybe trauma, or maybe von Willebrand disease, hemorrhagic diathesis, or thrombocytopenia. So autoimmune disease as well as trauma or drugs. And it's very important to understand when these factors are preventable and when we have to perform an early therapy and an early diagnosis. This is a very interesting and dramatic case of a child of 5 years. We already knew that he was hemophilic, therefore he was undergoing a therapy with eighth factor, but for some reason he suspended the therapy for a week and there was a trauma. Therefore, he presented with endoclonia, right limb hypostenosis, difficulty in speech, and here we can see the image. So the first line there are sagittal T1 and T2 weighted image, and on the last line we've got an axial T2, T1, and a susceptibility weighted image. Obviously, in this case, blood appears hyperintense on T1 and hypointense on T2 because this child unfortunately had a brain hematoma. And I would like to point out one important thing. In these cases, I know that the child bled, so it's clear that there's bleeding, but it's always important to perform this sequence, the susceptibility weighted image or the gradient echo, because in this case, blood that is hypointense is seen far better. So for a great bleeding is not important, but for microbleeds or for doubts it's very important to perform this sequence. This is another case of a neonatal ischemic hemorrhagic stroke. We are looking at the first images on the left. There are two imaging of T2 sequence at two different levels. Here we can say that in the right frontal lobe we have an ischemic lesion with hemorrhagic staining of the external region, and at the level of the cerebellum we can see nothing in particular. But if we perform a gradient echo and far better a susceptibility weighted image, we can say that there's a lot more to say. We can say that we've got hemosiderin staining in the right frontal region, in the right parietal region, and many other hemosiderin stainings in the left hemisphere. Perhaps the most striking image is the imaging we acquired in the cerebellum, because here we can see many microbleeds. What are these microbleeds? Microbleeds are small bleedings, very small bleedings, and in the cerebellum we've got thousands of these small bleedings. This is very important because we cannot think about a trauma or whatever in this child. We're thinking about a systemic condition because we have multiple and bilateral bleeding and stroke events. We studied a little bit more this child. He came back after 2 years, and we can say that especially in the right frontal region, we can say there's a porencephalic cavity, and in particular the tissue is substituted by cerebrospinal fluid. We also have some porencephalic cavity in the cerebellum. Here on the right. This child was affected by a deficit of COL4A1. This particular condition is related to an alteration of the metabolism of collagen. Therefore, the membrane of the vessel are quite fragile, and therefore they tend to rupture. Therefore, the breaking of this vessel causes many bleedings, and therefore many hemorrhagic as well as ischemic strokes, as unfortunately this child experimented. There are some peculiar, would like to say, mechanism for stroke in children. In particular, a peculiar mechanism seen in children, not in adults, is the mechanism at the base of the periventricular stroke. This is an ultrasound image. As we can see here, we've got hemoventricle. Here we've got blood that is hyperechogenic inside the ventricle. Blood inside the ventricle is called intraventricular hemorrhage. The presence of blood leads to compression and congestion of periventricular venous. The compression of this periventricular venous leads to periventricular ischemia, and this periventricular ischemia is the cause of periventricular hemorrhagic stroke. As we see here, this is a wide area of hemorrhagic stroke. This is very anterior, this is frontal, while in this case we can see that there is a periventricular venous stroke posteriorly, in particular in the left occipital territory. And this is very important because in this kind of strokes, the suffering and the bleeding is close to venous area of drainage and is not related to an arterial blood supply. Let's change the topic and let's speak about the infant stroke. Let's start with ischemic infant stroke. There are thousands of different causes for ischemic stroke. These are the most common at all. I would divide all these causes in main groups like heart diseases, hematological disorders, vasculitis that may be infective or non-infective, trauma, and hereditary disorders and metabolic disorders. I will show some examples of this kind of ischemic stroke. This is a child affected by lupus erythematosus systemicus, and this condition, as we already know, is a systemic condition. All the body may be affected, but in this case we're going to focus on cerebral alteration. In the first line we can see a T2 image, while in the second and the third line we have got diffusion and apparent diffusion coefficient. What can we say? We can say that there are multiple and bilateral areas of cortical suffering, in particular cortical area of diffusion restriction that is linked to ischemic stroke. And this alteration may be seen as hyperintensity area on T2 images. Moya-Moya syndrome. Moya-Moya syndrome is a quite peculiar syndrome that is diagnosed in patients less than 20 years of age in 70% of cases, and in 50% of cases is diagnosed in patients less than 10. So it's a very peculiar pediatric disease. It's a disease of children. What does moya-moya means? Moya-moya means a puff of smoke. Why? Because this is a kind of dysplasia, this is a disorder where we've got a progressive stenosis of the proximal tracts of the main vessels. Therefore, this progressive stenosis that causes ischemic stroke is related to the compensative hypertrophy of small vessels like lenticulostriate arteries and thalamoperforated arteries. Therefore, as we can see here, we do not see the proximal tract of the main vessel, but we can see what here, the hypertrophy of the small vessel seen as the puff of smoke. If no clear cause is evident in moya-moya syndrome, we can call it moya-moya disease. Let's have a look at this other case. This was a person affected by neurofibromatosis type 1. When we think about neurofibromatosis, we don't directly think as a vasculopathy. We think about something totally different, but we have to focus on one idea, that all children with seizures, headache, and no reasons to explain them in neurofibromatosis, we always have to perform an MRI, because neurofibromatosis is related to dysplasia. In particular, this was an incredible case, let's have a look at here, in which the right internal carotid was dysplastic. We cannot see in this stuff the internal carotid artery, and also in the reconstruction we can see that this artery is completely absent, is closed, and therefore the circle of Willis through the vessel from the other side supplied all the brain. Infant stroke doesn't only mean ischemic stroke, it means also an hemorrhagic stroke. Hemorrhagic strokes may be related to vascular malformative lesions. In particular, are going to present two main lesions: cavernoma. Cavernoma may be seen, as we see here on the T2, as a hyperintense lesion with a hypointense border. And it's clear here on the SWI, the susceptibly weighted image, as a large area of hypointensity, and this is well related to this alteration, to this lesion, and it can be multiple in cavernomatosis. Why here we have got an arteriovenous malformation. An arteriovenous malformation over here is a malformation in which an artery, or one or more artery, and a vein are connected through a nidus of arterioles or venules without capillary. And it's very important because here we can say that this lesion is prone to bleeding. Therefore, here we can see that there is an hemorrhagic stroke related to the arteriovenous malformation. When we think about strokes, we think about an arterial problem, but this is not always the reality. Sometimes we can have a venous stroke. The most important thing in neuroradiology when we suspect a venous stroke is that we do not have a lesion that is related to an arterial blood supply territory. Dural sinus thrombosis occurs in many cases. We can have some risk factors that may be congenital or acquired, and the presentation may be very generic. The most common clinical onset is headache, seizure, papilledema, so it's not very pathognomonic. Other and less common clinical symptoms may be diplopia, strabism, anisocoria, tetraparesis. When we talk about a venous stroke, we have always to remember the triad of Virchow. So hypercoagulability that can be congenital or acquired. Young women undergoing therapy with estrogenic drugs are more prone to have a venous stroke. Venous stasis, so the alteration of flow inside the vessel, or least but not last, vessel wall alteration. Trauma, infection, tumors may unfortunately cause alteration to the vessel that is more prone to be thrombosed. Which neuroradiological investigations are useful? Generally, when the child arrives at first aid, the CT with and without contrast is the first scan. On the other hand, I would like to say that there is an increased sensitivity of MRI at baseline and after contrast for thrombus detection. And as we have to remember, we do not have radiation if we speak about MRI. How can we see a thrombus? Generally, the absence of fluvoid on T2. When we speak about fluvoid, we speak about an hypointensity related to the flow of blood. And the thrombus tend to be hyperintense on T2. Obviously, this is a direct sign, and it's even better seen if we perform an MRI with contrast, because we can see the filling defect, and this is absolutely the last word. The appearance of this thrombus inside the venous may be alterated under some peculiar condition of the children. In particular, if the children is dehydrated, in relation to the age of the thrombus, the localization of the thrombus, but also the extension and the sequence we use. We will see that sequences are very different among each other, and it's good and it's extremely important to choose the right sequence in the right moment for the right question. This is a scheme and examples of the different timing in which we can perform MRIs and how the thrombus presents itself. So in the acute phase, it's very difficult to identify a thrombus. It can be hypointense on T2, generally iso-intense on T1, but is better seen on the gradient or susceptibility weighted image because it appears hypointense. The best moment and the easiest moment to see a thrombus is the subacute phase, because in this sagittal T1 we can see that the thrombus is quite hyperintense. Also in the last image the thrombus is quite hyperintense, it's clear, it's evident. And on T2 it tends to be hypointense. When we are talking about chronic thrombus, we're going to talk about a thrombus that appear nearly iso-intense on T2 and iso-intense on T1. And it's difficult to identify the thrombus in this phase. The better phase is the subacute phase. This is a very interesting case. This is a child of 15 years old. It was affected by leukemia and he was treated with L-asparaginase. He presented at our first aid because he was affected by headache, he vomited, he was affected by papilledema. What can we see here, unfortunately, is the presence of a thrombus. And the thrombo caused a sufferance, so there's a diffusion restriction for a sufferance and ischemic stroke of the tissue. Also here we can see the ischemic tissue, the ischemic brain parenchyma, and the blood staining over here. On the other hand, the best way to see a thrombus, as we already said, is a contrast T1. Let's see here, there's the filling defect, and this filling defect on the coronal image is called the empty delta sign. Empty because there's no blood anymore, there's thrombus that gives this appearance. As we see here in the venogram, we see filling defect of the superior sagittal sinus, and this is related to thrombus. This is an image, this is a coronal CT in which we see that there is a filling defect. Let's see the yellow arrow, there's a filling defect of the left transverse sinus. And the 3D reconstruction makes clear there's a filling defect, there is a thrombus, and there is no clear blood flow. We have already spoken about the periventricular ischemic stroke and about the sufferance of the medullary veins. The periventricular ischemic stroke was related to the hemoventricle. In this condition, we can say that it's not always evidence the presence of thrombus inside the vein. There is a pathology, a very peculiar pathology called transient thrombosis or transient engorgement of the medullary vein. Sometimes our patients are with headache, we perform an MRI and we just see subtle linear hyperintensity on T2 or on flare of the brain parenchyma. This hyperintensity is not related to thrombus. And in reality, the relation between the two events is clear because a transient thrombosis, a transient engorgement, caused the sufferance of the white matter tissue, but is not evident anymore, neither in these susceptibility weighted images. Therefore, there's the reality of a transient thrombus that dissolves under sometimes, but leaves the brain sufferance. This is a case. We didn't see any thrombus in the medullary vein, but have a look at this second line diffusion, last line apparent diffusion coefficient. We can see areas of diffusion restriction, and the very interesting thing is that the area of diffusion restriction follow the distribution of the deep medullary veins. Obviously, we can see here this subtle linear hyperintensity on T2 weighted imaging. These are the remnants, these are the results of the suffering of this white matter tissue. Unfortunately, we got some pitfalls. Not always what seems disease is disease. Sometimes it can be normal. Most common anatomical variants are dominant transverse sinus. What does it mean? It means that we can have two transverse sinus and one of them is dominant, is bigger than the other. Or hypoplastic transverse sinus. Generally, in this case, the sinus is hypoplastic, there is no thrombus, and there is a venous variant. The ipsilateral vein is generally bigger. Or the absence of the frontal portion, the upper sagittal sinus, like an hypoplasy or anaplasia of this region. This image is a venogram that shows the duplication, have a look at this, of the dural sinuses. So we got a duplication of the dural sinus, the superior sagittal sinuses, that is a not so common variant, but we have to think about it in order to avoid thrombus diagnosis. The last pitfalls I want to present are the arachnoid granulation. Arachnoid granulation over here are related to the metabolism of cerebrospinal fluid, and they are totally normal formations. In this case, this is a quite rare case, we got the cerebral herniation. So the cerebral herniation inside the dural venous sinus. It is quite rare, but we have to think about it, especially if there are no symptoms in our patients. The patient is absolutely normal, no symptoms related to this condition. My take-home messages: arterial stroke and venous thrombosis in children are relatively rare, but there is evidence of increased diagnosis thanks to neurologists, because you increase clinical awareness of this pathology, thanks to neuroradiologists, because neuroradiological technique improved, and thanks to all of you that work in the intensive care. Choosing the method of imaging in children is extremely important. Dose reduction and the possibility to better evaluating central nervous system makes MRI the neuroradiological exam of choice. Early diagnosis and tailored therapy allow reduction in neurological sequelae. Therefore, these are the main goals we have to reach. That was our last slide. Thank you for attending the lesson. I leave you our email address for every question. Goodbye and thank you again.